Very good evening to everyone. The title of my presentation today is Improving Diagnostics and Management of Patients with Acute Respiratory Tract Infection in Emergency Department. Here are my disclosures. So in the next 15 minutes, what I plan to do is to cover an important evolution in diagnostic virology. What I really mean by that is the shift from conventional antigen-based testing to point-of-care rapid molecular tests, and to more recently, point-of-care syndromic panel testing. So we will explore this important shift and discuss the need for syndromic testing for acute respiratory tract infections, describe the factors that influence performance of these tests, and discuss value of timely and accurate test results in management of patients in the outpatient setting. In the last few slides, I would share some of the most recent data from our laboratory on evaluation of performance of point-of-care testing for molecular tests for acute respiratory tract infections. So by way of introduction, acute respiratory tract infection is one of the top diagnoses in the outpatient setting. About 10 million outpatient visits occur annually, and children are disproportionately affected by acute respiratory tract infections. On an average, around $40 billion are used in the management of upper respiratory tract infection in outpatient settings. An additional $15 billion is lost in indirect costs due to caregivers taking care of patients. So it is a significant problem. When it comes to etiology of upper respiratory tract infection, we all know viral causes are the leading pathogens. Rhinovirus, influenza, respiratory syncytial virus, and many others that we are very familiar with. When it comes to pharyngitis, which is also one of the common upper respiratory tract infections in the outpatient setting, viruses remain the leading pathogens. However, about 15% of pharyngitis are caused by bacterial agents, and group A beta hemolytic strep is number one. So the risk factors are many: close congregations, asthma, smoking, allergic rhinitis, immunocompromising conditions. And so these are critical patients that need timely diagnosis, and we need to identify the right test for the right patient at the right time. So when you look at the sore throat diagnosis, despite pharyngitis being a main viral etiology, antibiotics are inappropriately used. So here is some data showing that more than 50% of adults receive inappropriate antibiotics, while only 10 to 20% really need them. And more than half of physicians are not following the recommendations for diagnostic group A strep testing and/or culture. So all of this results in overuse of antibiotic in the outpatient setting at the cost of about $1 billion in overuse of antibiotics, and more importantly, adding another $5 billion in combating antimicrobial resistance that's created because of this overuse. So how can laboratorians help this cause? Before we do that, as laboratorians, we have several tests in our toolkit. You have the cultures, the antigen test of various forms, and then you have the nucleic acid amplification tests. But one has to carefully consider all of these factors before you decide on a test, such as the age of the patient, the type of samples that are being received, and how the assays that you use are going to work with them, the viral evolution over time and emergence of new variants, the timing of the sample collection, exposure to animals, prior use of antivirals and/or vaccination, and more importantly, depending on where your laboratory is set up, the transport time is also going to play into the success of the diagnostic yield. So when it comes to outpatient acute respiratory tract infection testing, three things matter: the accuracy of the test, the timeliness, and the cost of the tests. So let's look at influenza antigen detection. So influenza testing. So here is a meta-review that shows that the rapid antigen tests are poor in sensitivity. They are anywhere about 50% for both flu A and flu B. The digital immunoassays improved it a bit, but you really need molecular testing, a rapid molecular test, to appreciate sensitivities in the 90%. So we decided to switch from an antigen-based test to a molecular test back in 2019 and provide this testing in the outpatient setting, both in the emergency and the urgent care. These are two separate settings, as you can understand. Here, high-risk patients, higher cost, and delay in the overall time, comparatively speaking, to urgent care, where this is low severe acuity, and the time to management of patients is usually in the minutes, usually around 45 minutes, the patients are treated and discharged. So with that in mind, when we implemented this point of care standard nucleic acid amplification test, we wanted to measure the impact of this test in the care of patients in the outpatient setting. So we provided education on the testing guidelines and invited the clinicians in the ED and outpatient setting in the urgent cares to participate in a 6-point survey, asking them on the clinical suspicion of the flu, was it low, severe, or moderate? And we asked them if they were planning to manage the patients with antivirals, antibiotics, additional diagnostic testing, imaging, and/or hospitalization. After they answered those quick 6-point survey, they ordered the test and the results were made available. And after the patient was discharged, we came back and reviewed the charts to see how the physicians used the test results in actually managing the patients. So let's look at the results of the study. So this study was done during the peak of 2019, over a 4-week time period, and we received about 339 surveys. So overall, this was a peak influenza season, so about 48% of the samples were positive, and predominantly a flu A viral season. And the median age of the patients in this study were around 4 years. As you can see, 140 surveys were received from emergency department and 199 from urgent cares. So when it comes to clinical accuracy of tests, of clinical diagnosis of influenza in children, it is really poor. So here, when the physicians said the clinical diagnosis was low or moderate or high, and when you compare that to the gold standard influenza testing, it all hovered around 50% margin. In other words, emphasizing the need for clinical testing in the outpatient setting. And here, when we looked at the management of the patients, so the sharp contrast is the use of anti-influenza antivirals. So what happened is really this point here, where many of the physicians, being peak influenza season, were ready to treat these patients. But once the test results were available, they did not. And so we reduced antiviral use by more than 97% in this patient population. So overall, when we looked at the patient management, nearly 70% of physician decisions were changed by the availability on an influenza test result. Most of this driven by the lack of use of antivirals or antibiotics, followed by reduced laboratory testing, imaging, and/or admission decisions. So when we really looked at the overall cost of all of this, in avoidance of additional costs, we saved about $150,000 in the matter of 4 weeks in 339 patients. When we extrapolate this over a usual influenza season where we test several thousand patients, we could save more than $1 million just in avoiding anti-influenza medications by using accurate diagnostic testing. So in conclusion, from this first study, clinical diagnosis of influenza in children has poor accuracy. Implementation of rapid molecular tests for children in the outpatient setting improved antiviral use, More specifically, for the flu-positive patients, appropriately received antibiotics, antivirals. Overall, clinicians changed 76% of their original management plan after availability of influenza test result, and majority of these changes were in favor of avoiding unnecessary expenses with the potential of overall cost savings for the entire healthcare system. So with that, I'm going to switch gears and move towards syndromic panel testing. Now, BioFire Spotfire respiratory sore throat panel was just approved a year ago. And so we wanted to look at the performance of this compared to the two other rapid point of care molecular tests that were available in the market, which is the Cepheid Expert Flu AB RSV SARS-CoV-2 test and the Cobas Influenza A, B, and SARS-CoV-2 testing. So just one slide on the Spotfire respiratory sore throat. Here it is one pouch, and you have two panels. With one pouch, you can test for both pharyngitis and or upper respiratory tract infection. You collect the appropriate sample type, the throat swab for the pharyngitis and the nasopharyngeal swab, and up to 15 or more pathogens are being detected by each of these test panels. So for the purpose of our study, we wanted to look at the four most common viral pathogens. So we selected 250 samples, 50 flu A, flu B, RSV, SARS-CoV-2 positives, and 50 negatives. And we compared them, we tested them on all three platforms, the Cobas, the Cepheid, and the Spotfire. And we considered a composite gold standard to which the performance of each of these panels were compared. And if there was a discrepant result, we extracted and tested it by Quant Studio singleplex PCRs. When you look at the results, overall, very good comparison between all these platforms. So we had an overall positive predicted agreement and negative predicted agreement, which exceeded 95% for all of these test systems and viruses, except for one exception, where Cobas had 9 false negatives for SARS-CoV-2, and therefore its positive predicted agreements was slightly reduced, about 86%. Another interesting finding is, because Spotfire has many more targets compared to these other panels, we had an additional 102 detections in this 200 samples, so nearly an additional 50% diagnostic yield with many of these viruses. So all of this is going to be helpful in an outpatient setting in possibly avoiding additional antibiotic use. Now, when we did a workflow comparison of these three assays for a batch of 10 samples, overall, the hands-on time were pretty comparable between the three platforms, between 1 to 3 minutes. But the results were earlier for Spotfire at 16 minutes, followed by Cobas at 20 minutes, and Expert at 40 minutes. As I mentioned earlier, time is of essence, and especially in urgent care, when the physicians are seeing the patients and trying to discharge them in 40 minutes, the time to result is going to be very important. So one slide on group A strep molecular testing. As we all know, the antigen tests are the first line followed by culture. And now we have option to use molecular testing, which one test result and immediate patient care possibilities. And again, here is data to show that rapid antigen test performance is poor. The sensitivity range anywhere from 44% to specificity on the lower range could be 69%. So it helps to use molecular testing in these outpatient setting to appropriately manage antibiotic decisions. So in conclusion, I would like to say availability of syndromic panels is going to provide you the rapid results with improved accuracy. Comprehensive detections of pathogens is certainly going to help medical care systems to realize outbreaks and manage their patients accordingly. Easier workflow and high throughput testing. An overall better understanding of the epidemiology and respiratory illness in children. And there is a huge potential for reduction in overall healthcare costs. Now, the laboratory budget is going to increase, but certainly the benefit of this testing is going to be seen in management of the patients and improved patient care. And the key to implementation strategy should be to consider the right patient population, proper patient selection, the right clinical setting, and the physician engagement before we offer these tests. So with that, I conclude, and I'll come back later for questions. Thank you for your attention.